I have a few questions for the top table just based on feedback I've been getting. Just explain, first of all, in relation to the gallium scan and octreotide scans, the beauty of getting the gallium scan is that an octreotide scans, it allows the tumors to light up like a Christmas tree when they do that. Gallium scan is even better. It's going to provide, I suppose, an even more detailed, more sensitive scan for people. And that's the beauty of getting this facility in St Vincent's. And we went to Jerome about it to support that. We didn't want it to go to another hospital because we didn't want people to be having to run all over Dublin or elsewhere for that to be in another centre, because it's going to help our patients group. Now the questions I want to raise, the first one is, we went to see Jerome as well about this notion of maybe people going to a consultant in one hospital and maybe he not being in contact with St Vincent's. I want to ask all the members of the panel who have a view on it, how vital is it, or how good are the contacts between the network of hospitals, or from a patient's point of view, how vital is it that you get onto the register in St Vincent's, that you start being channeled through the Centre of Excellence? The second question is, could maybe Dermot explain to people the monitoring that he believes is necessary, how frequently, what sort of tests you feel people should be having after they have been diagnosed, as in bloods and urines and scans, and how often that should be taking place. And the third question is for Lisa, who's the nurse manager coordinator who deals with our technical queries on an ongoing basis. What are the lessons you're learning, Lisa, from your day-to-day experience with us? For instance, is it that we need to know to ask for the prescription every 6 months for our pharmacy? Or where are we falling down? Or what are the kind of complaints you're receiving from us? What's the feedback you can give to us as a patients group? Thank you.
The idea of referral, the whole design of cancer service in this country is based on volume, that patients go to high volume centres and high volume surgeons where there are a lot of similar cases, but all the disciplines are there on the diagnostic and the treatment side. I occasionally still get comments from individuals who are not involved in this group, who are not working in cancer centres, saying, I'll treat whatever comes through the door. And I just have found that I'm losing patience with that approach from people. It's not appropriate in the 21st century. It's not a model of care that any other country would accept. So I would endorse the kind of consumerization approach where people who've got a rare disease, complex management, have every right to dictate where they get their care.
Thank you for that, and I think that that's really important. But despite that, and despite the fact that we've got a Centre of Excellence model in Vincent's with 2 satellite groups in Cork and in Galway, and you know Greg Leonard, some of you know Greg Leonard is in Galway. His name wasn't mentioned earlier. He's an outstanding oncologist, and you know Greg always asks the right questions, and he's the first person to give us a call, Justin or Kevin, one of the other surgeons, or you know whoever. Great cooperation. So while we see, I don't know, the vast majority perhaps of patients within that structure, that triumvirate structure, let's say, there still are patients in Dublin who want to come to see us just for an opinion, and they really find it an obstacle. There's a sister university hospital that sometimes butts in obstacles for patients that come across the road, and I don't care, this is political, but this is important. I mean, if patients want to come and see us, you can vote by your feet, you can contact Lisa, myself, Jerry Daly, who is our administrator, and we'll see you. We'll see you hopefully within about 2 weeks, and maybe even the next within a week. But the point is that if you're finding it difficult, it's a terrible situation to be in, because you feel like you're caught between 2 stools, don't you? You don't want to upset the person who's looking after you and all the rest of it. But I don't know politically how we can get over that finally. You should not be involved in a struggle. It should come from, you know, you're asking, well, I heard about this group, let's say in Cork, for example, and I don't know where you are, might be in Kilkenny or somewhere, I don't know, Waterford. It should be that it's just an automatic thing that they say, you'd like another opinion and that's it. And I know that many of you struggle with this. So all I can say at the moment is you can vote with your feet, you can ring us yourselves. We'll arrange so you don't have to go through that political turmoil of confrontation, if that's the case, with the team that's looking after you. We'll try our best to sort that out. And sometimes we've had to take over care completely, bypassing the other group, and that's the reality of life. I don't know, Jerome, how we can, get beyond that. I feel that over time this has sort of improved, because what we've done is that we've seen patient X on a Friday morning, we've agreed or not agreed with a treatment strategy, and then we've written back and we've discussed it with them, and the therapies have changed, and they go back to the referring centre, and that works very well. So, but there still is little teething issues to deal with. So,
if you just compare it to other services, so for instance, I do clinics on a Friday, and I'd frequently see men with prostate cancer, women with breast cancer, and they'd say they're a bit surprised how quickly they got through the process, how quickly they were seen, diagnosed, and treated. So the services over time build reputation, and if your service is accessible, and if patients have a good experience, it's going to generate a certain amount of momentum. You will certainly find at some point that you're having so many patients coming in that you need more resources, but that's a different argument. So I think it's a question of communication, events like this, and I think patients do get to decide. I mean, technically speaking, to see a consultant, you need a referral from a GP, not necessarily another consultant, but I think actually there's no stopping patients saying contacting services directly.
Can I just say that we had a social event last night, and there was quite a lot of people with this specific problem of how to get a referral into Vincent's or maybe one of the other satellites. And I know you say contact you, Dermot, or Lisa, but I think we need a streamlined way of doing that, and something that's more formalized to give, so that we can share with people how to do that. Because we always get asked the question, how do we get in touch? And obviously we can't be giving out your phone numbers or email addresses, so we need some sort of formalized system for doing it.
Okay, well, first of all, I'd like to say thank you, Tommy, for asking me those questions, and just to give me the opportunity to say that I feel very privileged to be in the position I'm in, and I absolutely love what I do, and just very humbled by all the people we see every Friday in the clinic. First of all, Mark, just to answer your question, we've been discussing, because we are being audited for the National Centre of Excellence, we've been trying to look at a generic sort of email and fax that all GPs and all consultants and every hospital in Ireland could access. And the pancreatic, I think the NCCP were looking at that first, and we're obviously following on with ours. So hopefully in the new year we will have a general referral email and a contact that everybody will get the referrals in, because at the moment, yes, we do get referrals from GPs to the secretary, to the nurse, to Dermot, to all the different people. So I do agree with Mark that it has to be a little more streamlined. I suppose the most important part of my job, I feel, is to coordinate all the care and all the patients. So when they do come in to see us in the clinic, that they have been discussed at our MDT, and that we have that decision from all the major sort of players, the surgeons, radiologists, pathologists, gastroenterologists, everybody there. And so that when the patient comes in, it's not just Dermot or Justin or whoever it is saying that this is what I feel. It's a whole group of people have looked at all the patient's scans, their pathology. So it's a really fantastic I think place for the patients to come in and see us and have a decision made generally by all these people, all these experts. So for me, I like for the patient to come in, have been discussed at our MDT, have their prescriptions, to come in and mention the prescriptions. Sometimes we forget and we don't say, do you need a prescription? But hopefully from now on, all the patients maybe could take that responsibility on. So we're not just posting them out every other week and you're emailing about that. Obviously I never mind, but I think it would be well organised if you sort of take that part on. And just to make sure that you have your bloods, we've had it before about the chromogranin A, it does take up to 4 weeks and maybe longer sometimes. So when you do come in for your scan, we encourage that you get your blood done then, and that we have all your information at the MDT. I don't know if there's anything. Well, I don't know. I suppose the patients would have to tell me what problems they've encountered, but I think it's more sort of maybe trying to get MRIs and time, those kind of things. I can't think of any.
Do we still have problems with blood results not being ready when patients come in for
That's
their...
what I was just saying. You know, just to have your bloods done well in advance. You know, it's hard for somebody who's coming maybe from Donegal to have their scan and, you know, to have their blood. Sometimes it might be just a month before their outpatient appointment, and when they arrive, the chromogram level isn't back. So, and we do like to have it done in Vincent's Hospital.
Thank you. Can I just, Tommy, just the test, this is my proposition. I've tried very hard. And you know, you cannot succeed on your own, and that's why we're here together. But just following on from Lisa's suggestion, I would also, and Charles talking, why don't we try to collectively, as a group, have, and we bring along Patrick Toomey from biochemistry. What we need to, in Vincent's anyhow, we need to have at least 4 or 5 tests that are not farmed out, and that is a group that we actually have in-house by next year, in situ, so that we can report back to you and sort of say. So I would be very happy that the patient group would try to leverage some opinion on this and to get that across the line. There's always a tiny bit of resources, but it's just unacceptable. We cannot be, and this is what the Centre of Excellence auditors are going to say, why is this going to a place called Biomis for done and all the rest of it? And you know, so this will, I hope, come from this auditing process as well. But if it doesn't come from that, I'd be very happy to have the patient network support in terms to trying to leverage that. But it's vital. Look, we just got millions to put in a PET CT scanner for gallium. So this can be overcome, I think. It has improved a bit.
You know the 6-monthly routine or the 9-monthly routine. What sort of tests do you want to see your standard patient?
That's, yeah, again, Tommy, it's sort of, it is a little bit individualized, but a lot of you will have a scan every 6 months. And when you go out to a scan at 9 months or 1 year, it's usually that we're happier. And even some patients are out to sort of tests that are a little bit beyond that. Sometimes we, you know, for some aggressive type of tumors, we like to see a control after 3 months or 3 or 4 cycles of therapy, so that we're not missing the boat. We're not backing a non-winner, if you like. So, and we're very happy then afterwards if we've got a good response or stabilized, or even better if it's gone down a bit smaller. So, Tommy, and the recommendations, we follow the guidelines from these ENIT guidelines. We follow it very strictly. So it's 3 months, 6 months, 12. Ordinarily, it would be unusual unless you had a very, very low-grade tumor. Sometimes every 2 years we do it for appendiceal, little small neuroendocrine tumors, to make sure that the liver is fine and stuff. And we try to, and I think this is something that what I mentioned about the terms of the feedback as well. I think we also need to have written information a bit more about follow-up and the circumstances of follow-up, and to involve you with regard to that and let us know as well. So that I think that communication is very important. The bloods then usually parallel those scans, Tommy. If you have this carcinoid syndrome, we don't always do it every time we do the urine. Now, for this 5-HIAA, if you've had it done, you know what it is. It's a bit cumbersome. There is a blood test that our biochemist is looking at bringing in for this 5-HIAA. This seems equivalent, much easier. I don't know if you're doing plasma 5-HIAA, but we're looking at doing that as well to simplify matters. So usually they run in parallel.
In Sweden, we have a government that has told us to create national health care program for abdominal net, which we have now, and lung net. Talking about that question is coming up. But the interesting view is that any doctor in Sweden that has a net patient can go into a web page and find this program or national guidelines, and you can look there at what level you should treat the patient. Some issues may be dealt with in a primary care, some issues in a local hospital, or some issues in a university or regional hospital. So it's stated there, and it's all also connected to patient registry, which is not, it will be start to running next year, and beginning of next year, this registry. So we will soon see how many patients with NET we have in Sweden. Every patient has to be registered, and every patient has to go through a multidisciplinary conference. So there is the goal. We're not perfect in Sweden, as someone said, but we're trying to. The goal is to every patient that has a NET should be registered in this registry and pass a multidisciplinary conference. And if there is a change in treatment, again, pass a multidisciplinary conference, and it's also registered the change of treatment in this registry. And it's all guided by these guidelines. That's the goal. We're working on that. And I think that's good to have some structure around everything that guides everyone.